What's in the basic record? Identifying data, contact information, fee and billing information. If you are dealing with somebody who is disabled, guardianship and conservator status, and a documentation of informed consent. The issue of careful documentation of informed consent cannot be overemphasized. Both from an ethical and a legal point of view, there must be an informed consent. There must be documentation that the client, or if you want to call them the recipient of services, knows what is going on, what this service is all about, what, if any, limits of confidentiality there are, and if there is going to be disclosure to a third party, to whom the records will be disclosed and under what circumstances. Legally, the concept of informed consent means that there has to be competency. Once again, the person has to be competent to understand the consent, that it has to be voluntary. No one has forced them into this situation. And what is called sufficiency of information. They have to have enough information to make a decision as to whether they want this service or not. All of this should be documented within the record. As I said before, if there are any waivers of confidentiality, such as in a forensic setting, that has to be made clear within the record. And if there are mandated disclosures, such as Dr. Walker mentioned a moment ago, child or elder abuse or abuse of mentally disabled individuals, that also has to be documented. The basic record should also have the presenting complaint, an assessment, a diagnosis, relevant history, treatment plan, and the actual contacts with the client, sometimes called progress notes. Those contacts with the clients should be fairly detailed. The date of service, the duration of the service, the type of service provided, the nature of the professional intervention. In other words, is it psychotherapy? Is it some kind of diagnostic assessment? The assessment of the client's status, any kind of supplemental information related to the patient care, the client responses to the interventions, risk factors to violence, for violence to self or others, as we talked about before. Have some sort of protocol for the assessment of violence to others and violence to self. Incorporate that, keep it there, keep it available. Any kinds of adjunctive treatment modalities like medication or biofeedback, these should also be documented. Any kind of emergency interventions, plans for future intervention, information describing different aspects, qualitative aspects of the interaction between the client and the mental health professional, dates of assessment, consultations and referrals, telephone, mail, or email contacts, cultural factors, prognosis for treatment, and documentation of termination.
Yeah, I just want to add something with your basic records. Many of us who are busy clinicians, especially those of us in independent practice, go from one client to another and really don't have opportunity to write all of this at the same time. Sometimes we, at the end of the day, are so exhausted that we really don't write everything in. My understanding is that you can at least cover yourself by making sure you have the date of service, that you have the type of service, such as individual treatment or group treatment or family treatment, and you have, if you have in your basic record the listing of the goals of treatment someplace else, you can say these are the goals of treatment that we worked on in this session, and just list one or two of them if that's what you've worked on. In just need a couple of sentences. You really don't need all of this if all of this didn't happen. Of course, if there's any kind of issue of violence or of abuse, or you hear about something that's different, or you change your goals of treatment, that there's a change, you put it in that session. Progress notes, the old kind of progress notes that you and I learned how to do when we were first learning therapy, really do not need to be in the record, and may make it even more difficult in the record, because nobody else wants to read them except you. But if you have those few sentences, and maybe at the end of the month or so you do a kind of little summary of where you've been, that may be sufficient for you to have in your record. Would you agree?
I would agree. I would agree.
Good.
Yeah. And I think the point that Dr. Walker made about not everything having to be in there, again, we did learn to include mountains of material, which really might make clinical sense from a psychodynamic point of view, but really is not relevant to the overall progress of treatment. Remember, that's the point of the notes, is to track the progress. So there should be an assessment, a treatment plan that derives from the assessment, and that the progress notes basically track the treatment plan.
Good.
Now, I mentioned HIPAA before, and a little bit of the confusion about HIPAA. HIPAA is designed for the protection of the client or patient. And a number of state laws are also very protective of clients' rights. So the question sometimes comes up, well, which trumps which? Which do you follow, the state law or HIPAA? And the answer is whichever is more protective of the client or patient's rights. So state law trumps HIPAA if it is more protective, and HIPAA trumps state law if HIPAA is more protective. But, of course, the problem is defining what more protective, the words more protective means. As an example, psychologists have a long-established ethical obligation not to turn raw psychological test data over to people who are not qualified to interpret it. And we believe that that is for the protection of the client, of the patient, so that somebody is not going to misuse that data, use it in some way that hurts the client. On the other hand, the client says, I want copies of my test results. Now, which would prevail? HIPAA, of course, would say the client is entitled to everything that's in their chart, so they can have the test rights, because that's more protective of their privacy and their autonomy. The clinician would say, no, the state law that says that you can give it only to another clinician who understands, who can interpret those tests, that's more protective, because just distributing it to the client could harm the client. So you sometimes get into these dilemmas about which is more protective. Okay, let me talk a little bit about different kinds of progress notes. First of all, HIPAA allows the keeping of what are called psychotherapy notes as distinct from progress notes. Psychotherapy notes are what we used to call process notes. This, in fact, was what Dr. Walker was referring to before, about the very detailed records full of hunches and speculations and psychodynamic formulations. And we can still do that. HIPAA says that this should be kept separate from the rest of the record. So we have a progress note which just says Client appeared, is making more progress, more depressed, less depressed, medication increased, medication decreased, and so on. And then in a separate record, and we're not required to keep the separate record, but HIPAA says if you want to keep a separate record, you can, in which you document all of these other things. And the idea of the separate record is to keep it private, is to keep it away from the prying eyes of insurance companies who might want to check on what's going on with a patient. And in fact, sometimes insurance companies will say, I want your entire record. And the HIPAA regulations are quite clear. You don't have to show them the psychotherapy or the process notes. You only have to demonstrate, only have to show the progress notes. Now, it's never really been legally tested whether or not these psychotherapy or process notes are legally discoverable. Most attorneys say if it came to a test, they probably would be. So they are safe from insurance companies, but not safe from legal discovery. So again, keep that in mind if you're planning to keep this separate set of notes. Sometimes we have what have been called SOAP notes, S-O-A-P. And sometimes people still, clinicians still keep their records in this way. SOAP, the S stands for subjective, O is objective, A is the assessment, and then P is the plan. So it's documented in that little acronym, which sometimes helps people keep their records together. And it should always be tied to the treatment goals. Dr. Walker mentioned before, and I'll just re-emphasize, notes should be taken after each session, even if they are very brief, and you can then later do monthly summaries. Okay, Dr. Walker has some case examples that we want to turn to now.
Okay, let's talk about a few of the cases that we have actually heard in one way or another. Sometimes when we sit in the licensing board hearings, sometimes we are actually asked to work on cases by people when they've got some issue or problem that's come up.